Okay, thank you, Dr. Saleh, for this introduction. It's a pleasure really to be here. So in the next 15 minutes, I'll try to make it 10 because I think we are behind. We're going to talk about pediatric MASLD, early identification and emerging diagnostic tool. First of all, I'm going to highlight a few things in the recent practice statement that's been published by the AASLD on MASLD in children. And if you look into the publication and the abstract in the last meeting in 2025, you will find them that they are focusing more into the biology, risk factors, modifiers of the MASLD. So I'm going to talk about early biology and risk factors, some advances in the diagnosis and the screening methods for MASLD in pediatric. So I like to start with this, that adult MASLD is often the result, but pediatric MASLD is where the diseases begins. So digging into the pathophysiology, digging into the things that precipitate or activate the MASLD in pediatric will turn later on into the adult world. So briefly, we know in children, MASLD is defined as hepatic steatosis confirmed by imaging and histology, plus at least one cardiometabolic risk factors, regardless of the elevated liver enzyme. We know it's now considered one of the most common causes of chronic liver disease in the children worldwide. The prevalence of MASLD in pediatric in US is 9.7% and globally is 7.6%. And it's actually getting higher if the child is obese, reaching up to 26%. Now I'm going to stop a little bit here into the pathophysiology slides. So once we think about MASLD in pediatric, the top driver for the MASLD pathophysiology is obesity. But we have to think about the background of this. Means there is a complex interaction of environmental and genetic susceptibility that push the liver from the regular status into the fatty status and then later on into the MASH. So if you look into this figure, you can see the prenatal factors like maternal age, obesity, some medication, smoking during the pregnancy, genetic precipitations, especially PIMPLA A3. And of course, after birth, which we should work on it, is the ultra-processed food, dysbiosis caused by medications, and exposure to chemicals. All these works together to increase the prevalence of MASLD. So if we look into the first abstract that I'm going to highlight is about early onset MASLD in obese prepubertal Hispanic Latino children. And when they look into 170 children, Hispanic Latino, which they have high risk for MASLD, they are less than 10 years of age. And if you go into the guidelines of the MASLD, usually we screen MASLD at 10 years of age. So this is a younger age group who has high risk for MASLD, and they measure status of the steatosis. And the most important things here is the genotype. What they found in this study is out of 170 children, Hispanic Latino, around 1/3 of them, they develop MASLD, which is confirmed by MRI. Interestingly, that 83% of them, they have at least one high genetic allele for PIMPLA3, which is very important here as another risk factors. So if we dig more into the kids who develop hepatic steatosis in this study, you can find that putting obesity plus the genotypes of PIMPLA3 GG increase the risk of MASLD into 75%, which is very, very high. So we conclude in this study that the interaction of Hispanic Latino plus obesity plus these genotypes will define the pediatric population at extreme risk to develop MASLD. Means we have to screen certain types of kids at earlier stage so they can get benefit of early intervention, either pharmacological or non-pharmacological. So when we think about children who are obese, they are not all the same. Some obese children will develop MASLD, some they will develop MASH, and some will develop nothing. So what are the risk modifier here in these children? So I like this abstract also when they think about 6 hormone as also a driver to develop MASLD. So they took around 300 children and they measure their 6 hormone and they measured MASLD marker. As you can see here in the graph, this graph, the one on the left side, you can see each pubertal stages. You can see the male sex hormone increase the risk of MASLD, while the female sex hormone actually are negatively associated with the MASLD. Same thing when we talk about steatohepatitis. So clearly that sex hormone play an important role here in the development of MASLD, and it can work independently and influence the MASLD severity. And this is also help us to explain why it is male predominant. So another thing here, do children with MASLD who carry pathogenic variant in monogenic liver disease represent a different clinical or histological subgroup? So if you have one of the important mimicker for MASLD is LAL. So lysosomal acid lipase deficiency is one of the mimickers for LAL because they usually present with a fatty liver. So in this study, they took a large cohort from NASH, which is more than 3,000, and they look into the children and adult with biopsy-proven MASLD, and they did a whole exome sequence for them, targeting the LAL. And they compare the finding with a matched MASLD group. So what they found here is, we know LAL is a rare condition, almost like 0.6%, almost like 22 carriers, and they compare it with the matched MASLD. They found that there is no differences between the presentation, prognosis, complication. Saying this, so heterozygous LAL variant do not explain anything related to MASLD severity or complication, and we have to stop overcalling the LAL carrier as a disease. Another important thing here is once we diagnose MASLD, usually people, they think about fecal microbiome. And in pediatric, they thought the different way. Let us think about fecal microbiome, and then let us think about what happened later on if he developed MASLD. So this is a very nice study. They look into early changes in the fecal microbiome, which are associated with the MASLD. So they looked into 87 Latino infants, and they collected the stool at the age of 6 months, 1 year, 2 years, and 3 years. And then they assessed the MASLD disease at the age of 5 to 8. What they found is, out of this 87 Latino infant, 8% developed MASLD, and they found really a unique fecal microbiome in these kids. They have lower alpha diversity and they have distinct beta diversity. But after the age of 3 years, at the age of 3 years, there are no differences in the fecal microbiome. This will tell us that the differences in the fecal microbiota was detected as early as 6 months of age in the children who later developed MASLD, and the early life exposure, especially before 3 years of age, may shape the gut microbiome and contribute into the MASLD development. One finding here that they found that there is abundance of bifidobacterium, which was low in the previous study that they blame it's related to MASLD. Let us think about different things like exposure to chemical compound here. So we all know what is PFAS. PFAS is a chemical compound. They call it the chemical forever. And usually this found in the cookware, some clothes, some plastic. In this abstract, they would like to see if the PFAS exposure, especially in kids, will affect the development of MASLD. So they took a two cohort of people, the solar group, which are the younger age group, and the meta-air, which is the older age group, and they measure the blood sample for them for the PFAS compound. You can see here the solar group in the three figures here, that there are the exposure of the PFAS group increase the odd ratio of the development of the PFAS, and the age interaction was playing a major role. Means what? Means the PFAS was first and then the disease happened later on. So there are really relation between the PFAS or the chemical exposure into the development of the MASLD. So back to the practice statement of the AASLD, when they stated that the screening is recommended in children more than 10 years of age with overweight or obesity and cardiometabolic risk factors, and ALT remain the primary screening tool. But we know it's the primary screening tool, but having a normal ALT will not rule out the MASLD. And imaging is not validated for population screening, and there is no validated non-invasive biomarker beyond the ALT. So what other solution that we can do? So one of the abstracts is the using of Velicure as a point-of-care test for pediatric hepatic steatosis. So they took a group of kids, like around 100 Hispanic Latino children. They are going to assess MASLD by doing the MRI, and in the same day, they measure the Velicure. So what they found is that the Velicure is helpful in ruling out the disease with high negative predictive value of almost 84. But it's not good in a simple steatosis, may be good in moderate steatosis. Still, we cannot use this as a diagnostic or screening tool, but something we can validate later on. Another thing is the multi-omic signature of MASLD. Do you have a biological fingerprint of MASLD that we can detect early in life? So what they found here in this abstract, that they measure the proteins and metabolites in these two cohorts, the discovery cohort of solar and the validation cohort in meta-air. What they found that there are really identified signature model for the MASLD, around 25 proteins and 5 metabolites. And these actually model trend in children and also validated in adult later on. And this is tell us that the MASLD biology is already present in the childhood and the disease signature may persist across the age. I can conclude here with the smell of MASLD. So we know H. pylori infection, usually we use the urea breath test. Do we have a breath test that we can use to diagnose MASLD? And this is one of the interesting, actually, abstract, looking for the breath volatile organic compound signature in children with MASLD. It's a prospective in the Children's Hospital of Philadelphia, where they look into children between 4 and 20, and they group them into two groups, the MASLD group, which are confirmed MASLD, and another group, obese with normal ultrasound. Actually, what they found is a 10 unique compound identified with the breath test, but one of these compounds has a higher sensitivity and specificity reaching 85 to 77. So if the things, I think maybe in the next 2-3 years, maybe one option to use as a screening if you have a normal liver enzyme. Finally, treatment reality in pediatric MASLD, actually there is no pharmacological therapy is approved for MASLD at this time, and lifestyle modification remain actually the foundation of management. Yes, there is adult approved medication that can be used in pediatric, but we talk about above 18 years of age. Medication which is approved for obesity might be used and might be get benefit if the child has MASLD. GLP-1 receptor agonists, there are really extremely limited study on it. The last one was done in the Children's Hospital of Philadelphia, where they found it is really benefit in kids who has really MASLD and obese, and they get it for a treatment in improving the liver enzyme. Bariatric surgery is one solution, especially in kids with severe obesity. I can conclude here that pediatric MASLD can begin early and long before it's clinically recognized. Genotype, 6 hormone, and early life modifier can shape the risk. Environmental exposure act during a valuable window in the childhood. ALT still remain the main screening tool. These are the new diagnostic approach, and thank you so much.